There's a very exciting number of participants who are joining. So good morning, good afternoon, and good evening, dear friends. My name is Ines Tofalo. I'm a Trust Fund and Project Management Specialist at the UN Office for South-South Cooperation. And it is my great pleasure to be here today moderating this session with such an illustrious panel of participants. In the past 3 weeks, we have shared with you tools for disaster risk reduction, approaches to health emergency preparedness, and concepts of South-South cooperation. We hope that you found them very helpful. It is great that you're participating in this 4th training session of the UNDRR, UNOSSC, PAHO, and WHO Joint Certificate Training Program. Let me give you a little bit of the logistics of how the event is going to run. To ensure that we have the best quality audio, we have muted all participants, but we do expect a very active Q&A. So we invite everybody to put their questions in the Q&A panel at the bottom of their screen, which is better than the chat. This webinar is being recorded, and the recording will be posted in the UNDRR UNIA and GETI YouTube channel, as well as the platform for this training program, where you can find all other recordings as well as all other materials from this program. For those wishing to get a certificate of completion, let me remind you that it is mandatory to attend at least 3 live sessions, to complete the post-training survey, and also to pass the exam with a score of at least 80%. The survey and the exam are already available on the platform and will be available until the 20th of September. We will send you an email with all the details and to remind you of the deadline, but we do encourage participants to review the materials before then. You have 1 whole week to prepare, and you will only have 1 opportunity to submit your results and get your score. That's why we encourage you to do a review. Today's webinar is an integral part of the Global South-South Development Expo 2020, which is currently happening in Bangkok, Thailand. And we also encourage you to visit the many side events and virtual activities that are taking place in this context. It is a hybrid expo, so you will find a lot of materials online. In today's training session, we will be focusing on South-South cities exchanges on transitioning to living with COVID-19 and managing complex risk scenarios. We have national authorities and local authorities from Bangladesh, from Santiago de Chile, and from Bangkok in Thailand that will share their experiences and good practices. And following this, we will have a 20 to 30 minutes Q&A session and a wrapping of the full training program. In this regard, let me pass the floor. It is my pleasure to welcome the first speaker, Dr. Gottfried Schreerab, Head of the Country and Sub-Regional Coordination at PAHO WHO. You have the floor. Thank you.
Thank you, Ines. So good morning, good afternoon, and good evening to everyone. I speak to you from Bangkok, Thailand, where we've just concluded the 2nd day of a very interesting expo for the global South-South development. I encourage you to go to the website. There have been extremely interesting sessions, both yesterday, today, and also tomorrow. So those of you who are interested in South-South cooperation, and even if you're interested in what's happening in the global South, please do visit the site from the UN Office of South-South Cooperation. And I want to also thank our hosts, Thailand, for putting up a very, very, very important and good event. I would like to start by greeting all the prestigious and experienced speakers who are with us today, and of course, all the participants of this important joint training that in the last 3 sessions have had the opportunity to learn from experts and from each other's experiences at national and local level. Today, we will also learn from our panelists who are in the front line at the local level. Territories provide unique opportunities for innovation and intersectorial action for achieving the goals of the 2030 agenda. And to achieve this, we require good local governance. For example, in the region of the Americas, the movement of healthy cities, municipalities, and communities has over 30 years of experience promoting health at local level and working with a health in all policies approach and a very intersectorial approach. Other regions have similar examples to learn from, which brings an opportunity for promoting South-South cooperation, exchanging good practices and knowledge among cities. It is within this context that we need to be looking at what is happening in the world around us. And at the local level, local governments were at the front of the response of the COVID-19 pandemic, attending the needs of their population and their territories. This year, a publications on cities' responses to COVID-19 has been produced through a collaborative work with UNOSSC, the UN Office of South-South Cooperation, UNDRR, and PAHO, where the innovative approaches of cities, the capacities to adapt to new challenges, and the importance of the sectoral approach to face crises has been well documented, and it could help replicate these approaches in a different context or to scale up to other levels. The 2030 agenda is indivisible. Although we have a number of SDGs, to be able to achieve SDG 3, SDG 11, SDG 13, or any of the SDGs, we must work towards collaboration with other sectors, addressing the 2030 agenda in its totality. Political commitment is needed to strengthen efforts to build resilient cities. It is important to strengthen the role of local governments for policy making, which should be aimed at promoting the investment on building resilient infrastructures, working on assessing risk, and planning to reduce those risks. Also, promoting health and well-being through designing public policies and convergent agendas in areas such as mobility, air quality, physical activity, and health are all very important. We need to remember that health does not stand on its own, and what we call the determinants of health need to be addressed if we want to really have healthy cities. Local authorities' engagement is critical. They know the needs of their population. They know the insights of their cities. And this brings an opportunity for a better tailored planning that responds specifically to the need of those populations. However, these results cannot be achieved alone. It requires the commitment of all sectors. Effective local government action needs to be accompanied by close coordination between the different levels of government: national, subnational, and local. Fostering social participation and civil society engagement is also important, and using a participatory assessment supported by local epidemiological profiles and communication strategies that facilitate interventions in the places where people live, where people work, where people study, where people play is essential. We hope that after this final session, you will have gained new knowledge and strengthened your capacities to start building forward and building better after the COVID-19 pandemic, addressing the social and economic determinants that condition sustainable development, and also to start working towards the transformation that all of us want to see in place in the environments where we live. Health is a key aspect of development, and we all need to work together to make our citizens and our world healthier, not just less sick. Healthier is a different concept. It's a concept of collectivity. It's a concept that needs all of society approach. It's a concept that drills down to the level of the individual. And that's why it's important that we have this kind of interaction that we're going to have today. And it's important that you listen to the experts that are going to expose their experience of the COVID-19 pandemic, but also that you share experiences between yourselves, both at this level today, but also in the future, where now you've established a good network of people who you can relate to and you need to work with. So thank you for your active participation. Thank you for all those presenters who have made this course so invaluable. And thank you, of course, to the organizing team that has worked so hard to ensure the success of this program. Thank you, and over to you, Ines.
Thank you very much, Dr. Schreiber, for those very inspiring remarks that I think have a lot of encouragement for cities to engage in greater South-South cooperation. And indeed, as you said, we're now going to go to the city level, to the experts that are implementing these initiatives. It is my honor to introduce Dr. Beatriz Chamorro, Health Director of the Municipality of Santiago in Chile. Dr. Chamorro will present in Spanish, and you can choose the relevant interpretation channel in the globe icon at the bottom of your screen. Thank you. Chamorro, the floor is yours. Dr. Chamorro, the floor is yours.
No se escucha.
Ahí sí. Buenos días a todos y a todas. Es un placer estar en esta instancia donde uno puede compartir la experiencia. Voy a compartir inmediatamente la presentación. ¿La están viendo todos? ¿Sí?
Sí.
¿Están viendo la presentación?
Sí, sí, doctora, sí.
Ok. Bueno, Santiago de Chile, capital de la región metropolitana, 527.000 habitantes, con un sistema de salud mixto en cuanto a 2 centros de salud dependen del Servicio de Salud Metropolitano Central y 4 dependen de la administración municipal. La emergencia nos llega a todos en el año 2020, en que nosotros tenemos que enfrentar como ciudad un prolongado confinamiento. Santiago fue una de las ciudades que estuvo con más tiempo en cuarentena, fueron 4 meses seguidos en la primera instancia y posteriormente tuvimos 2 meses de confinamiento. Teníamos altos niveles de positividad, mortalidad y además de ocupación de camas UCI. Llegar en algún momento a tener un escenario de aislamiento total con cierres de colegios, comercio, parques, que solamente se permitía salir con pase de movilidad 2 veces a la semana y uno tenía que acudir a una instancia de la policía o carabineros acá para dejar registro del por qué salía de su domicilio. Por otro lado, los trabajadores de la salud, de los centros de salud de atención primaria, que funcionamos con una cartera de prestaciones desde el Ministerio de Salud, garantizada, donde están los controles de salud, los controles de crónicos, las atenciones domiciliarias, tuvimos que suspender esta canasta y colocarnos a disposición de lo que el Ministerio de Salud dispuso en ese momento, que era la toma de el PCR, la trazabilidad, el seguimiento de los casos, la vacunación y en algunos casos cuando estaba sobrepasada el nivel hospitalario, nosotros en nuestros centros tuvimos que tener una hospitalización prolongada de algunos de estos pacientes y además dar continuidad a 2 prestaciones que fueron bastante protegidas, que era la entrega de fármacos en domicilio porque ya que las personas no podían salir de su domicilio, de su casa, hacia un centro de salud, y eran pacientes crónicos con tratamiento prolongado, se le entregaba en su domicilio, así como también nuestro Programa Nacional de Alimentación Complementaria, tanto para niños, embarazadas y adultos mayores, también fue entregada en los domicilios. Por lo tanto, empezamos, igual que me imagino que todas las ciudades de todo el mundo, en el 2020, en que no sabíamos cómo se comportaría el virus, no teníamos tratamiento efectivo y no teníamos vacuna, pero sí contábamos con una larga trayectoria en políticas públicas, en trabajo en redes, tanto asistenciales como intersectoriales. Tenemos una trayectoria con bastante experiencia en campañas de vacunación masiva en el país, y tenemos organizado nuestro sistema de salud donde la atención primaria es la puerta de entrada a la prestación de salud, y de ahí es derivado a los otros niveles de complejidad, ya sea especialista o hospitales. La estrategia fue la pesquisa precoz, que es lo que nos caracteriza en la atención primaria, el aislamiento de los casos, y empezaron a haber operativos que nosotros hacíamos en lugares específicos, y otros que eran en buses y que íbamos a buscar en los diferentes territorios, el realizar la PCR. La trazabilidad fue un seguimiento de casos y contactos, tanto telefónicos como con visitas domiciliarias en aquellos casos que lo requerían. Se instaló el sistema de residencia sanitaria para aislamiento de los casos para aquellos usuarios en cuyos hogares las medidas de higiene no nos permitían, o de conectividad no nos permitían hacer un buen seguimiento. Como les había contado, la cuarentena con la inmovilidad de las personas, ahí impactó mucho lo de las determinantes sociales que hablaba al comienzo la doctora, porque el hacinamiento en casas dependió mucho del nivel socioeconómico de cada uno de nuestros usuarios. Había casas en que teníamos 13 personas en menos de 60 metros cuadrados, y por lo tanto nos desafiaba a ser creativos y por lo tanto buscar cómo aislar el caso en esta residencia sanitaria y hacer el seguimiento de... El cierre de colegios también fue algo que impactó y que demoramos un tiempo en empezar a hacer las clases vía online, con lo que también significaba que debería cada casa contar con el sistema de computador y con el sistema de internet para poder seguir estas clases. El cierre del comercio, tanto el cierre del comercio como el no poder acceder a ellos alimentos hizo que el país entero comenzara a distribuir canastas de alimentos, del cual todo el municipio puso a disposición a todos sus diferentes departamentos para que llegara a todas estas casas. Y además, en algunos casos, por un tiempo, además de las cuarentenas, tuvimos toque de queda. O sea, a las 10 de la noche había que resguardarse hasta el otro día a las 5 de la mañana, y por lo tanto también hubo patrullajes que no fueron por los parques, por los lugares en que habitualmente se reunían las personas, para en forma preventiva y educación empezar a instalar estos de. Por lo tanto, Santiago, como ustedes pueden ver en la imagen, tuvo 4 meses de confinamientos, donde las calles estaban completamente vacías, donde toda la municipalidad, todos los departamentos de la municipalidad se abocaron a poder acompañar a sobre todo a nuestros adultos mayores, que en la ciudad de Santiago, por ser una ciudad con población envejecida, estaban algunos solos, así que departamento social, departamento de aseo, departamento de seguridad, estábamos en contacto con todos los equipos y diferencias. Eso fue en el año 2020. En el 2021, ya con el tema de la vacunación, tuvimos que abordarlo de tal manera de que los equipos teníamos que elegir puntos claves para que la población se acercara. Acá en Santiago tenemos un parque muy grande, que es el Parque O'Higgins, donde se abocó el primer vacunatorio. Después también tuvimos en centros culturales, y tuvimos en iglesias, muchas de las iglesias nos abrieron sus espacios para poder vacunar. También contamos con buses que el CEREMI, que es la Secretaría Regional Ministerial de Salud, y el Ministerio de Salud pusieron a disposición buses en los cuales, con mapas de calor, donde se veía que había la mayor cantidad de casos, podíamos abordar e ir a vacunar en esos sectores. Hubo una reconversión de todo lo que hacíamos en los centros de salud, y tuvimos que empezar a hacer también las consultas, o la telemedicina, o la teleconsulta, la cual era novedad acá para nosotros en el sistema público de salud, el empezar a contener a nuestros pacientes crónicos y también a todos nuestros pacientes de salud mental, en los cuales los hacinamientos tuvo un impacto bastante negativo dentro del individuo y de la familia. Y se sumó en el año 21 para la red de salud de Santiago el incendio del hospital más importante de la red, que es el Hospital San Borja, que en enero, en la foto central pueden ver que se incendió y que tuvimos que readecuar infraestructura, y Santiago también ofrece parte de su infraestructura para que se instale el servicio de oncología infantil, que hasta el día de hoy está funcionando en dependencias municipales. Por otro lado, se activa todo el sistema de consulta telefónica para poder ayudar no tan solo desde el área de salud a toda la población, sino que en todos los servicios básicos que necesiten, en hacer simples trámites, pago de cuentas, el poder ir haciendo todo el sistema online. A continuación, este año, seguimos con la tercera y cuarta dosis, nosotros de vacuna, y tenemos que retomar las prestaciones que en primera instancia, por estar en cuarentena, se reactivan. Volvemos a retomar los controles de usuarios crónicos, y lo hacemos a través de una nueva modalidad que es el CICEP, que es la estrategia de controles integrales centrados en las personas, lo que nos permite también focalizar nuestra atención en una sola visita al médico de todas las patologías que contienen. En esta etapa que estamos retomando, hicimos la evaluación de aquellas estrategias que nacen con la pandemia y que sin lugar a dudas van a permanecer. Una es la telemedicina, otra es todo lo que podamos hacer en talleres para casa, en talleres de vida saludable, en mantener la actividad física, en la contención en salud mental. Nosotros tenemos salas de rehabilitación integrales que estaban más bien enfocadas a rehabilitación osteomuscular, y a todo paciente que estuvo hospitalizado por COVID empieza su rehabilitación inmediatamente después del alta. Y en el tema de salud mental, que afectó a usuarios, funcionarios, a la comunidad total e integral. Posteriormente, para avanzar, lo que nosotros llamamos acá en Santiago el síndrome post-COVID, que va más allá de todo el aspecto biológico, físico, y que involucra mucho la salud mental de toda la comunidad, y la exacerbación de las patologías que por estar en cuarentena por un tiempo prolongado, también afectó todo el medio ambiente y la compensación de estos pacientes. La rehabilitación de secuelas físicas y psicológicas de los usuarios post-COVID se está haciendo bastante presente en esta época. Otra cosa que tenemos que enfrentar como comunidad es el retorno de los estudiantes después de 2 años en clases online. Esta reinserción social, esto de volver a estar en sala, además con distanciamiento físico, con el uso de mascarilla, con el lavado frecuente de manos, que se mantiene como, por supuesto, como medidas preventivas en nuestros colegios, también ha hecho interactuar de forma diferente a nuestros alumnos, y Estamos trabajando con equipos de psicólogos, con equipos de profesores, para volver a esta clase esta nueva forma, ¿no?, de asistir a clases. El reactivar la economía respetando las medidas de autocuidado también ha sido un tremendo trabajo multisectorial. Pues Santiago Centro se caracteriza por tener el mayor turismo, la mayor cantidad de locales comerciales de alimentación, restaurantes. Entonces, hacer terrazas, pedir pases de movilidad, uso de mascarilla, el depender de poder abrir un local de acuerdo a la etapa en que se encuentra la ciudad en que está ubicado, ha hecho que mucho del comercio, sobre todo en el área de alimentación, se haya visto muy afectado, y por lo tanto nos ha obligado a generar terrazas fuera de los locales para esto del aforo y de los espacios físicos. Reencontrarnos con la comunidad es otro tema muy, muy importante. La participación social, que es muy característica en nuestra atención primaria de salud, donde las decisiones, donde la calidad de la prestación, donde la sugerencia es un trabajo muy, muy directo con la comunidad, se había visto también bastante interrumpido en este tiempo de pandemia, así que el retomar el trabajo con la comunidad ha sido algo que hemos priorizado junto con la salud mental. ¿Qué aprendimos? Yo creo que aprendimos muchísimo. De Santiago, que a pesar de que tenemos 527.000 habitantes, transitan por nuestra ciudad como 1.900.000 diariamente, que vienen a hacer sus trámites, que vienen a trabajar, que vienen a hacer sus compras. Por lo tanto, el mayor desafío que nos mostró es poder diferenciar, porque los puntos de vacunación masivo que pusimos, vacunábamos a todas las personas que llegaban espontáneamente, independiente que fueran de la comuna de Santiago u otro lugar. Pero el sistema informático que tenemos de registro de vacunas define por residencia. Así que finalmente muchas de las vacunas que pusimos fueron a aportar a la cobertura de vacunas de otras comunas y no la de Santiago Centro, con esta cantidad y aflujo de usuarios que tenemos. Así que ahí lo primero que aprendimos es que íbamos a tener que ampliar este registro no tan solo de vacunas de residencia, sino que por también lugar donde trabaja. La muerte en general que nos dio el COVID, tanto a las familias que lo sufrieron como a aquellos equipos de salud que estamos muy relacionados a través de la comunidad y de la visita domiciliaria con nuestros usuarios, nos impactó por igual. Impactó al equipo de salud y necesitamos apoyo, necesitamos contención, necesitamos el poder hablar de lo que ocurrió con tanta muerte en nivel domiciliario, como a nuestras familias, que acá en Chile, la muerte de un familiar generalmente se produce en el domicilio con un rito de velorio en el cual viene toda la familia, amigos, visita, y después se traslada al cementerio. Eso se vio absolutamente imposible en tiempos de pandemia. Los pacientes fallecían en el hospital, salían desde el hospital hacia el cementerio, acompañados por 4 personas, y eso afectó mucho, mucho la despedida, entre comillas, esta forma de despedirse de un familiar se vio eliminada completamente por el tema sanitario, y quedamos al debe con la familia. Habrá que aprender del cómo hacemos cuanto en estos casos para poder mantener un trabajo de duelo, un trabajo emocional, y se hizo por telemedicina en algún momento, en otro momento se hizo con los familiares más cercanos. Otro tema importante como determinante social son los ingresos del trabajo. Nosotros acá, cuando hicimos seguimiento, el no cumplimiento del aislamiento obligatorio generalmente se debió a la necesidad de salir a trabajar para el sustento. De ahí también es la iniciativa de salir con cajas de alimentos, con ayudas de diferentes aspectos sociales. Así que es un tema también que aprendimos y que sabemos que cuando nosotros aislamos o cerramos las ciudades en cuarentena, este es el gran riesgo. Así que también nos llevó a evaluar cuarentena versus ingresos familiares. Otra cosa que nos aprendimos mucho de los centros de salud familiar es que el modelo de salud familiar que se centra en las personas, pero también en la familia y en la comunidad, que se vio interrumpido porque eran prestaciones individuales las ocurridas en esta pandemia, nos obliga a entender que el modelo debe seguir. O sea, voy a domicilio, voy a atender a un paciente, pero también tengo que estar enfocado en ese momento, en su familia y en su entorno. Otro aprendizaje, teletrabajo. ¿Ya? Nosotros estamos acostumbrados a que las prestaciones son directas, son en el centro de salud donde acuden nuestros pacientes. Hacer la función en teletrabajo en tu casa significa dos cosas: aprender a hacerlo, aprender a mantener el contacto nuevamente con el usuario a través de una pantalla, pero también significa que tengo que organizar mis agendas y hacer todo un trabajo administrativo diferente. Acá nos ocurrió que después de mucho tiempo, de 2 años de estar en teletrabajo, volver a reintegrarse a las atenciones presenciales no es fácil. No es fácil y hemos tenido que trabajar también en apoyo en psicológico y psicolaboral a algunos funcionarios para reintegrarse. Reconocer que la pandemia provocó también un gran desafío para los equipos, dado que se dejaron de hacer prestaciones directas y por lo tanto el equipo de salud está formado por médicos, odontólogos, está formado por TENS, por TONS, por administrativos, por nutricionistas, por kinesiólogos, y que todos aprendimos a hacer diferentes cosas, todos aprendimos a hacer a vacunar, a hacer PCR, a hacer trazabilidad, y eso fue un tremendo compromiso del equipo. Eso sí, en este país, en Chile, y yo diría que también, por supuesto, en nuestra ciudad, se vio el compromiso absoluto de todo el equipo de salud. Y haber trabajado en red. Yo siento que Santiago logra, y Chile logra enfrentar la pandemia a través de funcionar siempre, tener políticas de salud pública muy sólida, trabajar en red, trabajar con el intersector, entender que la salud es mucho más que los establecimientos de salud, que tiene que ver con educación, que tiene que ver con cultura, que tiene que ver con el servicio social o desarrollo social, que tiene que ver con infraestructura, que tiene que ver con que el país entero se vuelca a buscar las soluciones de acuerdo a la realidad local. Chile es un país muy largo, desde el desierto en el norte hasta la Patagonia en el sur, con los hielos eternos, y pasando por toda la ciudad, tiene que generar y generó políticas diferentes de acuerdo a diferentes territorios. Santiago aporta que por ser la ciudad, la capital, tiene mucha movilidad y tiene mucha gente que transita por ella, y había que poner los puntos, por lo tanto, de pesquisa, los puntos de poder lograr hacer una pesquisa precoz y una trazabilidad. En esto también, no tan solo estuvimos el sistema público, estuvo el sistema privado y el sistema público trabajando en conjunto. Se movió la red del país. Algunos pacientes, cuando colapsábamos en la parte acá central, se trasladaban pacientes a otros hospitales del sur del país, del norte del país, para continuar tratamiento. Yo creo que eso es lo más importante que pasa en Santiago. Nosotros estamos clarísimos que no podemos abandonar las medidas de uso de mascarilla, el distanciamiento social y los aforos como parte importante de evitar la propagación, pero también la vacunación es algo que para nosotros fue clarísimo. La tercera ola que llegó a Santiago que fue Omicron, llega con menos, estábamos en la cuarta vacuna, con menos sintomatología, con menos hospitalización y con menos muerte. Así que la vacunación es otro pilar importante que tenemos que seguir avanzando y viendo de acuerdo a cómo se comporten los parámetros de que si vamos a instalar o no vamos a instalar este otro año el que sea una vez al año la vacunación, que es lo que estamos conversando. Así que quedo abierta a las preguntas, quedo abierta a lo que ustedes quieran consultar.
Muchísimas gracias, doctora Chamorro, por presentarnos la dura realidad del COVID-19 en Chile, pero también sobre todo la capacidad de la Municipalidad de Santiago a responder y las innovaciones que realizaron. Creo que lo que fue más útil para este panel es todas las lecciones aprendidas y cuáles de ellas van a continuar utilizando en los años que vienen. Quiero pasar al próximo panelista. I would like to welcome Dr. Shabnam Mostari, Public Health Researcher, Aspire to Innovate, or A2I program of Bangladesh. A2I is the flagship program of the Digital Bangladesh Agenda, aiming to share insights and knowledge about public service innovation and transformation. So, Dr. Mostari, thank you very much for joining us. The floor is yours. Dr. Mostari, you would.
I think we may have lost her connection.
Okay, we're going to do a little reordering of the program, right? We will start with Bangkok and then return back to Bangladesh. I am pleased to introduce Ms. Tavida Kamolvej, Deputy Governor of Bangkok. She oversees a wide breadth of metropolitan issues, including public health and medicine, disaster prevention and mitigation, and strategic design and management. The floor is yours.
Thank you very much. It is my honor to present today. So I'm going to actually not dragging too much of the time. So I'm separating my presentation or my talk into two sections. The first one will be about 10 minutes. I'm talking about all the work that actually been confronting for the past several years, starting from the national level at Thailand national level, and now to not only Bangkok, it also a local government. I just took my position for 3 months, but before that, I worked with a lot of local governance and governments in Thailand. So let's see how the knowledge transfer from one to the others. And the last part of my talk today, I have a video clip of what we have learned in terms of managing, especially after COVID-19, and linking that to all the lessons learned that Bangkok is striving to. So, okay, let me share the slide first. 1 second. Let me grab a very quick in terms of what's actually been learned and been done from a lot of series of disaster that occur to the local governments. At first, you all know all of this already, that we've been actually confronting and dealt with a lot of disaster for the past like 2 decades. A tsunami in 2004 is actually alerted the national level of having a disaster warning system, as well as plays into the idea of having an local emergency service, which the local emergency service is not only the disaster and emergency response, but also including those who are doing public health emergency, as well as the MCAT. The MCAT is a medical unit that was designed in the local area to work with people who actually depressed and suffer and has a very bad experience in disaster. And that's actually creating from the national level down to the local level. And what is actually emerging from this disaster is our public health volunteers, which is one of the key factors that actually drive Bangkok and drive the local, any local provinces to survive COVID-19 first wave. I will get to that when we go to COVID-19. In mega flood in 2011, then Bangkok and the local government of Bangkok and the national level has a lot of conflict politically. And with that, it resulted in a very bad management in terms of the integration and integrative kind of process to work together. So by that, we then again realizing that the unit of Bangkok itself is actually dealing with a lot of flood problem, but the local government has never actually paid attention in terms of making itself having a unit that deal with disaster and emergency management. The only part of Bangkok that is changed from 2011 flood is creating a medical emergency service that is really getting stronger and stronger in terms of trying to dealing with the community disaster risk management. We put a lot of effort in terms of having a community be trained in multi-hazard, actually, kind of disaster. We're talking about if you have flood, then people of Bangkok is basically not only Bangkok, Thailand, still stay at home, even though in the middle of the water. So you are talking about having flood and then you're having outbreak that come with those people that actually stuck in their household for a while. We have 45 days of knee-high until head-high of water in Bangkok. When after that, when we realized to create that kind of team that related between what is a compound hazard that come with a disaster, which is flood, that we actually have experience on. Other than that is we have a problem moving people who is disabilities, and we move people who have chronic disease, and we also have a problem of those people who health is at risk, to evacuate them from the flood-prone area. That is still the problem that we have to solve as well. Then when we have earthquake in one of the local area in Thailand, what it has to do with Bangkok? In that earthquake that happened, we only have 2 deaths. But the problem is with that 2 deaths, it makes us realize that even though earthquake is actually not striking badly, but the cause of them is actually creating a structural damage, which cannot be seen by our own eyes. So basically, when you're talking about the move of the land, even in Bangkok, we are on the soft soil. So a lot of community and the buildings is also, they're not going to actually tear down because of any earthquake or any fire, but it will lead into a weakening of a structure. And that means that the community has to learn how to actually put the knowledge of seeing risk and risk identification and tie that with when you have emergency team from the local government to comes in, they need to actually know that what they're risking their life for, because we have a lot of cases that caused by fire and caused by an aging structure. And then suddenly we have a building collapse. So this triggers us that Bangkok needs a USA team, which is Urban Search and Rescue Team professionally. And that's what the lesson that we have learned from this event. PM 2.5 and COVID-19 has raised the problem, especially in Bangkok. It attacked Bangkok badly. And with these two is actually because Bangkok is very dense, it's very complex. The activity was there, is very packed. So we have a lot of vulnerable groups. We have a lot of people who has already have the risk at health as risk. They have chronic disease, and we couldn't actually get all of the help actually faster enough. Even though local governments in Thailand has a very strong public health volunteers, but the volunteers in Bangkok itself, you're talking about, we have 5.8 million registered population, but we also have child population, and that's about 10 million in the daytime, which means that when you have to take care of all of the people during PM 2.5 or even the COVID-19, it's creating a very difficult in terms of factors. Is the diversity of factors is a lot. People have to come in. There is a lot of labors going on. We have migrant workers that we couldn't taking care of. So it's not only when it's caused by public health, it's caused by health disaster, health emergency. The condition before, because we have a lot of poverty, we have a lot of bad data system. Bangkok never creates social safety nets, let alone that we don't have a very good big data in terms of managing this crowd and this segment. And the COVID-19 has actually reflected that. We even have a problem because we have a lot of accident at first. And when you have to go help people in an accident during an outbreak of COVID, that's not very easy. That is a change a lot in emergency service, in terms of medical emergency service, approaching to the patient, and with those PPE suit and with the new protocol that we have to serve them. Right now, actually at this moment, for the past week, we have a lot of flood coming in. And we have to manage a shelter. We have to manage a lot of things. And with that flood, it caused a lot of chemical leak. It also have outbreak for sure in terms of diarrhea. And we're still in the middle of the last phase of COVID-19. Thailand has not yet declaring it as an endemic. No, not yet. It will be on the October the 1st. So this compounding kind of chain reaction of each of the disaster causes a lot. And we have really a lot of problem in terms of creating this unit. Last but not the least, this is the last case that I would bring in. We have a fire. This case is very classic. Fire was actually is the most experienced operation that Bangkok as a local government has. We have a very good team in terms of firefighter. However, during that time, the fire happened in one of the Bangkok vicinity nearby. And 6 hours has passed. We couldn't actually extinguish the fire. And then we realized that there is a styrene chemical compound within this factory, which caused a lot of allergy, irritation, and then a problem of breathing, and those people who have condition. And then we just realized that you need another medical team, and we have to set out the unit, the mobile unit of this medical team to approach them and actually helping out. And we have to pull all the resources that we have, because primary care in Bangkok is not very well recognized. Actually, around a country, I guess. We actually expecting for tertiary kind of hospital system to take care of any outbreak, pandemic, epidemic, or any huge big disaster that has medical help in terms of operation. Then to all of this that we have learned, we think that what if we can actually make not only local government stronger, we need to push all of the improvement and development down to a local communities. One of the things that we can make a local community stronger is a network of public health who know how to do search and rescue. So right now, Bangkok is actually tying those of the medical operation, disaster search and rescue in any multi-hazard together, and trying to bring in all the team that actually can work to the community. We are trying to increase the level of primary care capacity. We're using a lot of telemedicine to actually help out that a lot of volunteers having doctor consultation, having an information of curing, and then get down to there. In the video clip that I'm about to show you, it would also let me wrap it up first, and then along the way of the clip, I would actually narrate a little bit more. In the video clip, you will see we're trying to use telemedicine. And that with that telemedicine, the consultation and all of the work that the medical team can actually help out in any disaster that occurs to the community would be better. It would be more efficient in terms of delivering help to the community. And you will also see what we call Motorland, which is a motorcycle plus ambulance. So basically within Bangkok, we have learned in any accident, critical patient, there is no way that we can grab 8 golden minutes. There is no way. So within that 8 golden minutes, we're creating what we call Motorland. This Motherland can approach to any scene within 8 minutes. With that, we will have our medical team with that Motherlands. The Motherlands cannot move patient, move us as a medical team to the scene, working with search and rescue team, get the help to a critical patient first, buying the time for another one, commute length. which is a community and communication ambulance, smaller. Get to the community that is very complex and dense, and get the medical team to help. With this commute lens, you can move people. And yes, of course, we having ambulance follow-up. So this is what I call sandbox. Bangkok has implemented 2 sandboxes already in terms of plugging in this medical team to deliver any disaster risk measure. So let me stop here and then give me another 4.5 minutes. Let me share the screen for the video, and then I will, 1 second. I will share the video and I would get the sound off so that I can narrate the sound. 1 second. Okay. You can see the screen now, right? Okay. This bird eye views of Bangkok, which is radiant. This is our governor. And one of his policy is actually good health, making a healthy city as well as a safety city. Safety and health is actually become in the same time. We are opening a sandbox, trying to link a sub-district and the public health center, which is a primary care in each of the area in this sandbox. And then it's actually, we are tying up with district office in Bangkok, 5 district offices with these of 6 public health center, which is primary care. The first system that we use is telemedicine. So all of the ambulances, commute lens, as well as mother lens with our medical teams actually communicate real time to the connection of the internet back to the hospital. So with this, our search and rescue team and our medical team approaching the scene with the doctors in the hospital that actually can see what we see and can help us conduct us how to do things. In the picture, this is at a very, very local public health center, primary care. The doctor in primary care is also having telemedicine, the system that can contact with the doctor as the hospital. And with this system, people at home can also use this system to talk with the doctor in terms of following up their kind of like symptom, and also if they have a question of any risk that they're actually getting into, they can actually communicate with the real doctor without coming to the tertiary hospital. This is a team of motherlands. This is our personnel in terms of health personnel that actually can communicate from the ambulance and the commute lens back to the hospital as well to help out. These people can get into the scene very quickly and deliver. We have e-referral, and this is motherlands that I talk about. And when you approach the scene and you try to help them within any kind of disaster as well with the search and rescue team, and you can buy some time so that the commute lens in the picture is a smaller ambulance that can get into the scene faster, following with that motherlands. And then all the helps actually can get to a community in the local area, very density, very quick. And this is also another ambulance that we kind of like altered a bit so that we can carry those of people who as the elders in the community. At any time the disaster occur, the elders would actually be the most vulnerable. So not only that, we ask them to be in our public health volunteer network. We also open the center at the hospital that can take care of the elderly palliative care. And then those people who actually have a health condition, this center would actually helping people as a shelter as well, and then can administer the life support, and we can actually taking care of a lot of people in the community. And last but not least, in the community itself, we creating a elder center as well as early childhood development center. These 2 centers would actually practically serve the primary purpose of developing the life condition as well as using it as a shelter when disaster come, and we have medical personnel there. Last that you're looking right now is PM 2.5, a moment ago, PM 2.5 detective kind of project using a local volunteers to actually following the sensors and have a warning of the health system that can affect their health to the elders in the community and the most vulnerable in the community. So these are the sandbox that we are trying to achieve. Hopefully if I have a chance next time to see you guys, I might be able to tell how much we accomplished from this sandbox. This sandbox is 1 month old, actually 2 weeks old. And we are trying to learn from that lesson and then expanding this sandbox around Bangkok. Hopefully that the goal of having safety city in any kind of disaster risk management can actually be combined with those health emergency and strengthening a local community to cope with this more disaster in the future as well. Thank you.
Thank you so much, Deputy Governor, for a really inspiring presentation full of very concrete examples, and also an explanation on how they helped you identify risks and how they help you, plan and respond, developing units, protocols, systems. So congratulations, really impressive. I see that Dr. Mostari was able to rejoin, and I'm now very pleased to pass the floor to her.
Thank you. Allow me to share my screen. Can you see my screen?
Yes, we are seeing your screen.
Okay. COVID-19. Oh, so before starting the presentation, I would like to share my name. I'll introduce it. I'm Dr. Shabnam Mostari, working at Aspire to Innovate, A2Y ICT Divisions, Bangladesh. COVID-19 is changing that context rapidly. Policymakers need dashboard with real-time data, not data gathered from surveys. Supporting during the COVID-19 pandemic, during the ongoing COVID-19 pandemic, the government of Bangladesh has taken numerous initiatives to provide healthcare and other necessary services to citizens. Since the first confirmed cases of coronavirus was reported in Bangladesh, the A2I program of the ICT division and the cabinet division, supported by UNDP Bangladesh, has been implemented initiatives in collaboration with multiple public-private stakeholders. A2I program, in collaboration with Director General of Health Services, produced use cases of leveraging ICT in healthcare management. Data-driven platform for COVID-19 case management supported vital health decisions of the government in COVID-19 response, such as high-risk case identification, disease progression prediction, hot zone identification, and resource allocation like health workers, testing facilities, hospitals, capacity, isolation unit, ICU capacity, non-prioritized vaccine recipient, and timely policy response like contact tracing, quarantine, partial lockdown, full lockdown, and timely policy response like non-health related like workplace, school opening, industry relief. This kind of initiative has been taken by A2I during the COVID-19 pandemic. So far, we did the data was collected from citizen self-report, automated contact tracing, report from COVID-19 test, frontline workers self-report, and report by community support team. Then data was analyzed by doctors. There was a 333 toll-free hotline number, which is called Doctors Pool. More than 4,000 doctors were involved with this initiative, and they provide medical advice and e-prescription to the citizen. And then data analysis and verification by doctor. Based on that, high-risk cases, hot zone was identified, and they recommend then which area would be locked down or not. Then there are multiple dashboard, and this dashboard was provided for giving support to the Director General of Health Service, IDCR, public and private, and some medical decision like dashboard, like dashboard for government administration, like for cabinet division of field admin and police. Based on this dashboard, the cabinet divisions will take necessary action in each area, and field administration will also take decisions, and police is working in this area to successfully lock down in high risk area. And some admin decisions in multi stakeholder communications like corona.gov.bd, TV, radio, community radio, phone, some social media. I'll share some use cases like self-testing tool. Citizens are accessing corona testing support through helpline 333, then 332, and one hotline number which is called Shastho Batan 16263, and 25 web app and web interface. A preliminary scanning through the self-testing tool identified 21 million initially suspected corona patients, 1.2 million primary at-risk citizens, analyzed by Telcom using machine learning. And we have collaborated with all the telco in Bangladesh, and we get the daily update from them. And based on that, that the government is take decisions in risk identifications. And then 1.2 million primarily at-risk citizens were identified from them through big data analysis. Out of them, 221K high-risk citizens were verified by doctor. The insights have been forwarded to the DGHS, I mean the Director General of Health Services, and IDCR to the everyday. Some use cases: tracking movement of COVID positive patients for contact tracing and home quarantine enforcement. The Corona BD app has been developed to provide information on potential corona patients and to enable self-testing infection risk at home. More than 9 lakh people have been download the app and are using the app. In addition, a contact tracing app has been developed to help identify corona patients and those who came in contact with them. Through this, the citizens are getting alert notification about the patient and suspected persons, person near to him, and to take and the precaution measure. Some use cases and hospitals' capacity and the patient's load, based on, as I mentioned earlier, that based on the telco data and the self-contact and the corona contact tracing app and self-testing tool. So there's a dashboard. So every day from the dashboard, the citizens get the policymaker get information on isolation bed capacities, and then receive information on suspected patients in each area, then isolation bed and suspected patient comparisons, and require isolation bed in each area. Use cases: hospital capacity, hospitals capacity, and the patient's load. Resource mapping may be helpful for early preparations. For that, I also mentioned earlier that isolation bed capacity. There's a dashboard for isolation bed capacity, suspected patients, isolation bed and suspected patient comparison, required isolation bed. And I'm sharing some use cases and hospitals information that from the bed occupancy. There's a dashboard. From the dashboard, policymaker get updated on hospitals' bed capacity in each area. I mean each divisions and bed occupancy rate. by divisions. Based on that, governments can take priority decision on whether bed capacity should be increased or not. Then the national COVID-19 dashboard. It helps to real-time disease progressions monitoring, policy guidelines to field administrations and field health administrations, real-time policy advocacy on resource allocations. In collaboration with the Cabinet Division, A2I has created a dashboard for the COVID-19 reporting system for the field administrations. Through this, the Cabinet Division, in coordinating the necessary healthcare activities and the allocations and distribution of relief by the field administrations. As the dashboard is fully functional, a decision has been taken by approval of Senior Secretary ICT, Health Service Divisions, to transfer the dashboard to Director General of Health Service. So we have transferred this dashboard to the health service divisions, and from the corona period, it was this dashboard was developed by the guidance from the Director General of Health Service. That time, the Director General ADG gave us tremendous support to develop the dashboard, and we get the data from the telco based on that, and the data from the self contact tracing 333. Based on that, we identified the high risk, low risk, and the no risk, and which is categorized by red, orange, and green color. Use cases, some use cases, zoning based on city corporations area. So high risk location identified and mapping. A2I is assessing the Ministry of Health and Family Welfare and the police administration in effective decision making by marking zone based high risk, low risk, and safe areas like red, yellow, and green on the basis of corona patients' positional information on the map. Using the zone-specific information on map, the government is able to expand area-based assistance, increase or decrease the number of doctors, supply the required medicine, manage hospitals facilities, and take necessary administrative action, including lockdown. Not only this area, while this area, as I already mentioned, that the red area was under complete lockdown. So under complete lockdown area, citizens are not able to come to outside of the home. That time, government of Bangladesh has taken multiple initiatives, not only medicines and hospital services. They are provided free food, those who need, and besides those who don't need free food, they just give a egg shop, A2I online platform, and egg shops. It's a digital platform. They communicated with the egg shop, and then they received the food services from there. Besides then healthcare services, A2I and Government of Bangladesh and the Ministry of Education has taken several initiatives for providing providing education-related service to the students, teacher, and the training to the doctors. There's online courses in the on the corona. 8 e-learning courses on corona have been added to the e-learning platform of A2I Muktopath. About 4 lakh trainers in trainees, including 26,000 doctors, have participated in Muktopath's online courses. Around 15,000 doctors, volunteers, nurses, private health workers, pharmacists have received certification from DGHS after the training sessions. Besides this, there's a digital classroom during the COVID situation. As we know that university was almost closed, so there was in collaboration with the Ministry of Education and the Ministry of Primary and Mass Education have created digital contents for primary, secondary, madrasa, and technical level students, which are being broadcasted nationwide through Shangshud television. So far, a total 650 online classes have been conducted, and more than 2 crore students, and 600 and more than 6 lakh teachers are onboarded. This digital content have been viewed about 3 crore times through online platform. For students unable to attend class online or on TV, a new hotline 3336 will be already launched to provide education-related advice and connectivity with teacher. That's the public person dashboard, which is called corner.gov.bd. The corner portal, www.corner.gov.bd, has been launched to provide citizens with necessary advice on coronavirus and information on all corona-related service, and to update them from the very beginning of COVID-19 outbreak. It includes progress and direction on corona, district-wise corona, hot zone on the map, AI-based chatbot, and all informations including national hotline and call center, IDCR hotline, healthcare call center, Shastro Batayon, Shukhi Poribar, 333 call center, which was conducted by volunteer Dr. Paul, and more than 4,000 doctors was on board in these initiatives, and around 2,296 content was uploaded in this corner portal. So far, citizens have visited this portal over 21 million times for corona-related information. A decision has been taken by the approval of Senior Secretary Health Services Division to ensure the the continuation of this portal. Moreover, it is also decided to provide suitable content of this portal for public awareness based on the need of citizens. There's a taboo while corona has been immersed in Bangladesh. So there's a lots of wrong information was disseminated in Bangladesh, not only Bangladesh, almost everywhere. So this dashboard was useful tool for the citizen to get the right informations, not only healthcare informations, only the food, the everyday how many patients are infected, mortality, how many patients is recover, and where to get tests, and where to contact for free tests. This kind of information the citizens receive from here. There's a mass distribution hub. During the COVID-19 crisis, a dashboard named Mass Distribution Hub has been developed, which was proposed by the Additional Director General Planning and Development of Director General of Health Service and permitted by the Principal Coordinator SDG Affairs, Prime Minister Office. This dashboard aims to monitor the distribution of masks throughout the country, along with helping policymakers to take decisions regarding mask distributions, number of distributed mass distribution organization, different type of mask, highest and lowest uses of mask in district level are demonstrated using geographically and map wise in the dashboard. Moreover, it consists of different initiatives taken by different organizations to raise awareness, along with different content based on mask creation and flight right uses. Different organizations can log into the dashboard to record how much mask they want to use. They want to provide a specific area. This information is visible to dashboard when district commissioner office approves it. As the dashboard is fully functional, a decision has been taken by the approval of Senior Secretary, Health Service Division, to transfer the dashboard to Director General of Health Service. For this dashboard, PRAC and others, few organizations work to help this dashboard. And overall development of this dashboard, it was developed by A2I, the guidance from the DC Health, FAO. And it was developed by the A2I, but guidance we received from the FAO, BRAC, and DC Health.
Dr. Mostari, we ask you to kindly wrap up so that we have the Q&A session, please.
Okay, sure. Voluntary Doctors Pool, an app named Voluntary Doctors Pool has been developed to provide online healthcare services. More than 4,000 doctors provide healthcare services to the citizen. As I mentioned earlier, that they provide free services, and the doctors they are not paid, and all the doctors are volunteer. The coronavirus outbreak has emerged in Bangladesh not just as a threat to public health, rather it has disrupted almost every aspect of life. Because of the highly contagious nature of the viruses, it has created a panic among the citizens. At such a moment of crisis, the inability to physically consult with doctors has emerged as a crucial obstacle for citizens seeking medical assistance. COVID-19 forced the healthcare delivery system to develop digital tools harnessing the available information technologies to help the citizens in terms of their need. The guidance and DG Health's 8Y ICT division started few telemedicine initiatives such as COVID-19 Telehealth Center, 333 Telehealth Center, Ma Telehealth Center, and Community Supporting Telehealth Center. The COVID-19 Telehealth Center is provided healthcare services for COVID-19 patients, and 333 Telehealth Center is for providing all kinds of services to the citizens, and Ma Telehealth Center is for providing healthcare service to the mother and children up to 6 years of age, and Community Support Team Telehealth Center is for suspected COVID patients. So this initiative was collaborated. We have implemented this initiative in collaboration with DGHS, FAO, BRAC, ICDGRB, and UNICEF. So COVID-19 for the COVID-19 Telehealth Center, a management information system, DG Health has established a web-based data collection system called District Health Information System. So to collect routine health data from the health facilities of Bangladesh. COVID-19 Telehealth Center collect COVID-19 positive patient information from MIs and import to the system named called COVID-19 patient information and service management. So how this operation, how it was operated in this the initial call for patient assessment. In this
Dr. Mostari, your presentation is really fascinating, but I will ask you to kindly leave some space for the Q&A, and I'm sure you'll have more opportunities to return on these matters.
Okay, I'll complete it within 2 minutes. So far, 15 lakh citizens have received telehealth services from the COVID-19 Telehealth Center, and 63 lakh citizens received telehealth center or telemedicine service from 333 Telehealth Center, and 4.28 lakh citizens, mother and children, received telemedicine services from our Telehealth Center, and 37,000 suspected COVID patients received services from Community Supportive Telehealth Center. And it was an overall operation of how telemedicine service was operated. So considering time constraint, I'm skipping this slide. And so what kind of how we operated patient data received, as I mentioned earlier, we receive patient data from the DHIS2, DGHS, and patient data validate and patient data insertion to the 8OA office. Then patient basic information collected from the doctor and health information officer, and medical assessment was conducted by the doctor, and medical consultation provided by the doctor, and patient follow-up and case close. And the medical, so I'm also skipping this slide. And so far, I'm sharing few data analysis from the data from the COVID-19 patients. So far, out of more than 2 lakh patients, 40,000 patients have comorbid disease, and rest does not have any comorbid disease. And proportion of comorbid disease, majority of the patients have the hypertension and diabetes mellitus, and the less amount of patients have the kidney disease, heart failure, stroke, asthma. And this is the comparisons between the telehealth data and PCR data, and the geographical locations almost same. The patient identified in PCR and the patient received services from the telehealth. It was supporting government Bangladesh, supporting vaccine registrations, reporting adverse effect following immunizations, issuing international travel certificate, supporting policy decision with a big data analysis. Thank you.
Thank you very much, Dr. Mostari. Really fascinating presentation, showing us with a lot of data the power of digital technologies to really combat COVID-19 and to deliver government services. There are a number of questions that are being raised, and I think this is a great opportunity to provide an opportunity for more interactive discussion. Okay, if I may start on a question addressed to Dr. Chamorro. It says, thank you, Doctor, very interesting to hear Santiago's experience on COVID-19 response. When you talk about providing food baskets, are you talking about food that has been designated to meet the nutritional needs of community members, as opposed to providing food based on where there's surplus food available? Dr. Chamorro, would you want to take this question? Oh, I understand she might not be available then. Then there's a question on education. During the pandemic period, was conducted to online delivery. Rural and poor communities not having the necessary infrastructure would not have had the necessary facilities. How are you addressing the widening education gap during this recovery period? Deputy Governor, you have the floor.
Okay, I saw a lot of asking in terms of also financing and those infrastructure. We have the same problem. Some of the let's make it two separate answer, which is coming together. First, of the infrastructure. Right now, believe it or not, a lot of private company and the private investment, especially service provider, has come to talk with Bangkok a lot. COVID-19 has bring us to understand that Bangkok itself, Bangkok metropolitan, has a limit. We can't take care of 100% of the patient or the people of Bangkok. We can only take care of about 30 to 40%. So by admitting that, we reaching out for help. Service provider, one of the service provider had already came to us and would like to provide a free wireless network within 12 hospitals that we have. And we are about to actually asking to share more as in that CSR to us to actually uplink the system of wireless to the area of 69 public health center in we have outskirt, which is outbound of Bangkok, which is a little bit more of the agricultural rural areas. So infrastructure had been set under the policy as well. We invest more in terms of having them using this self-repeated of the signal. So we are on the way of doing that in terms of infrastructure. It would fund by Bangkok as well as the private company that helped sharing this up. So that is free from the partnership. Second one is that, as I said, a lot of people who actually, even though there is an internet connection, they are not capable of using a device or skill in terms of using this telemedicine. We're providing the device, the free internet SIM card through the public health volunteers, which is in a local community. Next month, November, we would launch what we call technological volunteers, which is new generation of the group of the people that will come and actually help link the system to those in the very outskirts of Bangkok. And if I may add, I'm sorry, to the rural area in the question, I tried to answer in written already. To the question that about the rural area of Bangkok right now, this telemedicine, this internet connection is not only solely in Bangkok. The Ministry of Public Health already know that Bangkok is implementing sandbox. So they're using the same idea and trying to expand it to many, many provinces around Thailand as well. So we're moving on toward using this. So that would be my answer. I grabbed 3 more questions from the chat already.
Excellent. Thank you very much. Dr. Mostari, I see a number of questions for you relating to those Bangladeshis that are not online, regarding to privacy concerns and also the issue of data collection. I don't know if you want to reflect on those issues.
Yeah, I want to the questions. Yeah, we have for maintaining the privacy. We did not while the citizen downloaded the contact tracing app, he can just see the patients in nearest area, but which patient in each area it was not identified. Like a ward level area, the citizen can get the information that in each area, each ward or in each municipality area, out of 1,000 citizens, 10 citizens are suspected COVID patients or COVID patients. This kind of information citizens is received, but not. We always maintain the privacy. The patient did not, the citizen did not get the information which patient or which citizen is COVID positive, who is COVID suspected. We always maintain the privacy. And I received another questions. How does Bangladesh keep it real-time report on COVID-19 cases?
So, Deputy Governor, there's also a question about what are the key urban risk management and resilience strategies that you think would strengthen urban governance or better national policy and city implementation?
Okay, I can see some of the commentary I agree to, including answering this question is data governance. Bangkok, even though I presented to you, seemed to be fascinating, but remember this, it's still a sandbox, which means there is a limitation of Bangkok that cannot do all. And one of the reasons that we cannot do all because the data system is not very good. I need a sandbox to see if I can push some of the area that is most capable first. A lot of people ask me why I push this first. You need to know that you're right in some of the experiment that you do, otherwise you cannot move forward. So I'm pushing them in terms of core data. Right now we try to do what we call shared data together. All the hospitals, public health centers, we share resources, not only resource that we share, but we share the information of the resource so that we can manage the whole picture and relocate, pooling resource together. We still have lack of data about our vulnerabilities. That's we still lack of. So this is a must. Without this, you cannot do any of this kind of resilience because you have to know all the content and context of each of these segments so that you can serve them according to what they want. That's the first thing. Second thing, I think you need to reach out. You need to admit first that the local government is incapable of doing something. And instead of putting that incapability as a limit to start, you have to put that as something to solve. To go to anyone that can cooperate with, go to any data that available, go to any kind of resource that we can share, and tying it up with the goal of safety of the society. I think we get a lot of response there. And last but not the least, we found out, the whole country found out that volunteer system is really good. And if we can systematize upskilling those volunteers and then sharing some of the incentive to them, I think that would also help. So 3 factors.
Thank you very much. So there's a very active Q&A, lots of questions, lots of interest in this exciting presentations. I think it is now time to move on to the wrapping of the session. And I would like to give so I thank very much the panelists for your interventions and the active participants for your questioning. And I would like to give the floor to Mr. Sanjaya Bhatia, Head of Global Education and Training Institute of UNDRR. You have the floor. Thank you.
Yes, Ines, may we switch to have Heini first, please?
No problem. Let me introduce Ms. Heini Utunen, Head of Learning and Capacity Development Unit at WHO Health Emergencies Program. The floor is yours.
Many thanks, and really pleased to be here. And oops. Great, I had some alerts coming. So really pleased to be here on behalf of the Pan American Health Organizations and World Health Organizations teams that actually run the session number 3 last week. And I have a few key messages to convey from that session to the closing of this joint certificate program. So in our session on cross-sectoral approaches to all hazard health emergency preparedness, our experts from PAHO and World Health Organization were looking at the different elements of health emergency and disaster risk management, including resilient hospitals and tools and guidance that inform the practitioners at different levels on work related to this area. And a few key takeaways emerged. Number one, a common topic was arising to say that there needs to be a learning and adaptation work to make evidence-based decisions that keep people safe in public health emergencies. And there is a whole set of tools and guidance from the World Health Organization that inform in particular the health emergency preparedness and related disaster risk management. Secondly, with the most of the global population now living in the cities and urban settings, the cities are really at the heart of the efforts to understand and manage the health risks that are more complex than ever before. And there was a number of tools introduced for these areas, including for safe hospitals. And thirdly, just to say, us in the WHO and World and the PAHO, Pan American Health Organization, are really proud to work together with the UN Office on South-South Cooperation and with the UN Office on Disaster Risk Reduction to really go through these lessons and exchange, like the session today, on practices that inform us, the guidance developers, implementers, practitioners, on how can we keep ourselves and our populations safe. And we all have first-hand experience from the COVID-19, but as we heard here before from colleagues in Bangladesh and Thailand, that there is a wealth of experience in cities on how to manage all of these events and risks. And lastly, I would like to conclude by quoting our Director General, Dr. Tedros, his speech yesterday to the Expo in Bangkok. He started by saying that South-South cooperation is all about learning from each others. And this is what this program has been for us this year, now 3rd year on a row. It's learning, experimenting together, and taking responsibility collectively, as we've done in this session. And I would like to thank colleagues in UNOSSC and UNDRR for this great collaboration, and also thank for all participants who've been sharing and exchanging so actively. Many thanks.
Thank you, Ms. Utunen. I will now give the floor to Mr. Bhatia.
Thank you. So from our session, it was firstly the understanding that we are in a world where we have to deal with complex risks, and looking not only at the hazards themselves, but also the drivers of risk, and how all these risks are becoming interconnected and increasing the challenges in dealing with them. For example, COVID, which is with us for the last more than 2 years, but at the same time we still have the floods, the fires, the droughts, and the earthquakes, so and the hurricanes. So all this makes it a very complex situation. Secondly, looking at the system of systems approach. So that's the only way to deal with this more complex risks and the increasing complexity, is to approach with the system of systems approach, understanding that all sectors are interrelated, they are interconnected, and something that impacts one sector will definitely sooner or later impact the other sectors also. So we need to have all sectors, be it infrastructure, utilities, education, health, livelihoods, whatever, all of them need to be resilient. And then we looked at a tool, the scorecard for cities and the health scorecard. These tools are very easy to use. They are freely available. You can download. There is an online version also, and they are available in many languages. So, so go ahead and use them. They can help in determining the gaps in your systems. They can help in determining the actions that you need to take to address those gaps. And in that manner, they help in developing a plan of action to enhance your resilience. And lastly, I would like to, the last point I would like to say is that if any city is interested in following up on these tools, please do reach out to us. We'll be happy to have a dedicated session with the city and the local government. And before I end, again, I would like to thank UN Office of South-South Cooperation, World Health Organization, and the Pan American Health Organization for their cooperation, collaboration, and making this a success for now the third year. So, and of course, lastly, I'd like to thank all the people behind the scenes who have been managing the platform and the Q&A and others to make this happen, and all the participants for their very, very active participation. Your questions, we had to answer hundreds of questions, and that shows how engaged you were. So thank you for that. Thank you.
Thank you very much. I will now give the floor to my dear colleague, Dennis Nkala, Chief of Intergovernmental and UN Affairs at the UN Office for South-South Cooperation. The floor is yours.
Good evening. Thanks, Ines. Coming to you from the Global South-South Expo in Bangkok. My task had been to summarize the discussions, but I was not able to join because I was in another session, which it took rather long. So I will ad lib and say something from the observation of what I saw once I came aboard. I joined just about the time when they were talking about a lack of data. And indeed, it's been a recurring theme in most of the events that I've participated in the Global South-South Expo. But let me pivot a little bit and tell you about some of the messages that came from the Expo, particularly from the Secretary General of the United Nations, the President of the General Assembly. It is clear that at this point, we're at a point in our time where indeed there are complex emergencies, complex disasters that are happening. And so it is really very appropriate that you are looking at this subject of complex risk. However, to link this to South-South and triangular cooperation, which is the reason why we are here in Bangkok, it is important to see that what will take us through out of this is also the ideas underpinned by South-South cooperation, which is solidarity and working together. And so above the knowledge about the risk, above the data, we also have to have the methodology, the innovation to be able to solve the problems that we are experiencing. So this training, we consider to be part of the Global South-South Expo. And therefore, I would like to congratulate all the participants who went through the training. And certainly when I got to listen, I could hear that there was a lot of enthusiasm, a lot of questions. And finally, I would like, of course, to thank the UN Office on Disaster Reduction. Our partners, we have worked together, particularly in the region here when I was working in the region. And of course, WHO and PAHO. Yesterday, I sat next to the PAHO person who I didn't know that I would end up having to participate. Otherwise, I would have asked all the questions and I would have known what to say today. But thank you very much for your partnership. And over the years, during the expos, you have always been there, always sharing with the others. And we look forward for that to continue. And last but not least, to thank our city's project colleagues as well, who have been the conduit of connecting with you to work together. So with those few words, and I'm sorry again that I came too late, I have little to offer, but a lot of goodwill and looking forward to work together for the future. Thank you very much.
Thank you very much, Dennis. Before we move on to the closing remarks, in response to questions and just to stress, for those of you who are interested in getting a certificate of completion, the exam is now open and it will be until the 20th of September. If you have attended a minimum of 3 live sessions, we do encourage you to review the materials that are all posted on the training portal, because you will only have one opportunity to submit your results. If you can see in the screen, this is the navigation pathway to get to the survey through the top and the exam through the top bar. For those who were not able to attend 3 training sessions live, or for the broader audience who might be interested in this knowledge, the goal is to share it broader. So there will be a self-paced course on these topics that will become available through the openwho.org portal in mid-October. On that note, let me pass the floor for her closing remarks to Dr. Kutsia Huda. You have the floor.
Thank you very much, Ines. Good afternoon from Geneva. I'm very pleased to be here today with you all at the 4th session of this very important joint certificate training for local authorities and urban development practitioners. I'm Kutsia Huda, heading the Disaster Risk Management and Resilience Program of World Health Organization in headquarters. Over the past, more cities were created, and so our responsibilities. And this process is very dynamic. We have seen how cities were especially hit harder in the pandemic. While cities are the hubs of opportunities, unfortunately, such opportunities also are the breeding ground for challenges. Last year, from the webinar series that we ran on hospital and health facilities experience in this pandemic, in collaboration with UNDRR and international hospital federations, we heard from many countries across the world how the efficient health system, including health workforce and infrastructure, played vital role in saving lives and thus the development. Having said that, I believe considering biological risk at the center of risk management approach would be key. Complex risk management approach should be able to protect the workforce and the infrastructure, building on preparedness through response and recovery. So, a lot have been said during this session. So at the closing, I would like to just reiterate 2 aspects, which will be key in advancing the risk management approach towards resilient urban future, acknowledging cities has been at the forefront of the pandemic, with the local government and communities playing a critical role in the COVID-19 response. The first point would be using innovation and technology to manage risks in the countries and communities, and more so for managing complex risks. We need to think out of the box, drawing upon the lessons from this current pandemic. We need to learn from others. That's why such cooperation and collaboration are key. It is very critical not only to identify the risks, but also to prioritize them, matching with the existing capacities and analyzing underlying vulnerabilities. The world is changing faster, and so are its citizens. We need to be cognizant of those changes and learn to navigate through the changes to build a resilient future. And that's why innovation and technologies are very important. And we have heard from the country examples of Bangladesh, Chile, and Thailand how these are being used. My second but most important point is developing a robust leadership at every level, including cities. Leadership is key in bringing everyone together around identified and priority risks in this transition process, managing complex risk. While it is important to align all our actions and initiatives around risk, it is also important to take note of the fact that both resources and capacities that we have are limited. That's why one of the best ways to succeed in managing complex risk is to adopt whole of society approach, which warrants strong leadership at all levels. Again, we have heard this quite well from our Deputy Governor of Bangkok. For an effective risk management system needs a robust and risk-informed governance. And then I turn to all participants now attending this training program today who will be playing this role in many cities around the world. This is not the first pandemic the world has experienced, and unfortunately, it's not going to be the last. We need to blur the lines of geographical and cultural differences and do everything in our capacity to build synergies, express solidarity in this process. We need to build a culture of risk reduction, leaving no one behind. We do not have any choice, unfortunately. I think the process has started from this meeting, from this training today, where we already are here. COVID-19 and also the climate change related emergencies have shown us that we need to take urgent action to better understand and manage systemic risk to avoid facing similar catastrophic events in the future with equal or even more devastating results. These are pertinent because though the cities are currently responding to the pandemic, they also need to prepare for a world transformed by COVID-19. This is challenging, and we all have to come together to deal with this challenge. WHO is fully committed to be with you all in making our cities resilient. I would like to sincerely thank our partners, Global Education and Training Institute of United Nations Office for Disaster Risk Reduction, United Nations Office for South-South Cooperation, and Pan American Health Organization for this joint initiative. I thank all the speakers of the day for sharing their experience, knowledge, and useful resources from the countries, Chile, Thailand, and Bangladesh, highlighting the importance of local engagement in this process of building a better, resilient world for our future generation. I would like to thank all the engaged and very enthusiastic participants and all those are behind the screen to put together the show. Finally, I would like to thank Ines for your excellent moderation for today. With these few words, I announce the closing of this session. Thank you once again.